My name is Mar Carreño. I'm the director of the Epilepsy Unit of Hospital Clinic in Barcelona, and I'm also the president of the Spanish Epilepsy Society. I want to thank Sanofi for organizing this Epilepsy and Pregnancy webinar, and also for inviting me to speak. And I will be speaking about pregnancy planning in women with epilepsy. These are my disclosures. You will all agree with me that planning the pregnancy is always a good idea, even in women without epilepsy. However, this is especially relevant in patients with chronic disease, such as epilepsy, because it helps us to choose the best moment and minimize the risks for the mother and the baby. For a woman with epilepsy, which is the best moment to get pregnant? Well, when she has the best possible seizure control. We know that for some women with drug-resistant epilepsy, seizure freedom is not going to be a realistic option, but we must achieve the best possible seizure control. When she is on the safest possible AED combination, when she's taking adequate folic acid supplementation, and when she's going to have the adequate medical and social support needed through pregnancy. In spite of all these advantages, a significant percentage of pregnancies in women with epilepsy are unplanned. And there may be a lot of reasons for that. First of all, of course, the personal decisions of the patients. But sometimes these inappropriate decisions are rooted in insufficient knowledge of the women about the convenience of a planned pregnancy, lack of knowledge about the risks to the mother and the baby in the pregnancy, and insufficient knowledge about the interactions between some AEDs and some birth control methods. And I will speak about this later in the presentation. But the truth is that surveys performed among women with epilepsy show that there is limited knowledge among women with epilepsy about very important issues regarding pregnancy and childbirth. And many women state that they want more information than the information they have, mainly about risks for their children, and they want it well in advance of getting pregnant or even choosing the antiepileptic drug they are going to be taking. This information is most demanded by young women, women under 35. Overall, the preconception counseling received by many women with epilepsy appears insufficient, and that's something that has to change. What other things we have to discuss with women with epilepsy who want to become pregnant? Of course, we have to tell them about the general things we tell to any woman who wants to become pregnant. We have to advise the woman not to smoke, not to drink alcohol, to have a healthy diet, to get regular sleep and exercise. But in addition, in the case of women with epilepsy, we have to warn them about avoiding precipitant factors of seizures or those situations that can increase the morbidity of a seizure. For example, we have to warn them about bathing or swimming alone, climbing heights that, of course, they shouldn't do. They have to avoid sleep deprivation, taking toxic substances, excess caffeine, avoid sleeping alone or in a prone position, and be very compliant with medication. And of course, go to the doctor whenever needed to adjust the medication dose if that's necessary. And the truth is that pregnancy outcomes are poorer in pregnancies that are unplanned compared to planned pregnancies. And in fact, unplanned pregnancies are associated to a much higher percentage of spontaneous fetal loss. So planning the pregnancy is definitely an advantage for the mother and the baby. Compared with the group of unplanned pregnancies, we know in addition that planned pregnancies are associated to a lower seizure frequency during the pregnancy, to less frequent changes in dose of ADs during pregnancy because the patient is more stable, and to greater compliance to medication. It's not uncommon that when they have an unplanned pregnancy, the women get scared and all of a sudden stop their medications, and they may have life-threatening complications like status epilepticus. So how do we do this? How do we educate about the convenience of planned pregnancy? Of course, to avoid an unplanned pregnancy, one conversation we need to have is the adequate contraception. This is very important, and this conversation should be had well in advance the pregnancy and well in advance of sexual activity. Of course, this conversation needs to be tailored to the age of the patient and to the individual needs of the patient. It's not the same to educate a teenage girl or a grown-up woman, and it's not the same to educate a woman with a normal IQ or a patient with developmental delay. So we need to do that, but we do that every day in our clinics. And in addition, we should remind of this conversation frequently during the follow-up of the patient, because sometimes the patients forget, or sometimes their circumstances, their birth control methods are changed, and we need to bring up this discussion again. We know that the use of hormonal birth control methods is low in women with epilepsy compared with women without epilepsy, and this use is particularly low in women younger than 25 years. Only 17% of them use this type of birth control methods. Sometimes physicians are also responsible for not asking routinely about birth control methods, not emphasizing the need to take them, and not recording this information appropriately in the clinical chart. And this is something we really need to have in mind. The information has to be very clear. Those patients that are treated with enzyme-inducing AEDs may have failure of the hormonal birth control method. We need to tell them that if they want to have oral combined contraceptive pills, the dose of estrogen in the pill needs to be at least 50 micrograms a day of estrogen. If they have breakthrough bleeding, probably the dose should be increased to 70 micrograms a day, and probably without interrupting the treatment. And even so, probably the efficacy is not 100% guaranteed. And the same happens with the progesterone-only pill, the progestin implant, the patches, combined contraceptive, and the vaginal ring. They are not recommended due to reduced efficacy. The pod progesterone may be used, although it's a birth control method that is associated to significant side effects such as bone loss or delay fertility when it's interrupted. The levonorgestrel intrauterine system is also adequate for these patients treated with enzyme-inducing AED. And we have to warn our patients that the non-hormonal barrier methods are less effective than the combined oral contraceptive pill. In these patients, the non-hormonal intrauterine device may be the contraceptive of choice. The situation is different for those women that are treated with antiepileptic drugs that are non-enzyme inducers, and they may use this variety of hormonal birth control methods. A special caution must be paid to those patients that are treated with valproate. It's very important that we know that all patients needed with valproate need to be treated with an effective contraception during the whole treatment with valproate. And this means at least one effective method of contraception, preferably one that is independent of the user, for example, an intrauterine device or an implant, or two complementary forms of contraception, being one of them a barrier method. And in fact, when women with epilepsy go to an expert in epilepsy, to an epileptologist, many of them change their routine birth contraceptive method for an intrauterine device, and the reason is because it's the safest and most efficacious form of birth control without interactions with drugs. And the failure rate is as low as 0.2 to 0.8% per year, which is much better than the other methods. In spite of all this, we have to still inform our patients that most of them are going to have healthy pregnancies, but the risk of complications during the pregnancy and labor is going to be higher than for women without epilepsy. Which are these complications? Okay, there may be risks for the mother and these risks for the baby. Some of the risks for the baby are associated to the antiepileptic drugs the mother is taking, and sometimes we may need to adjust the medication and change the drugs before the patient gets pregnant to reduce the risk. And whenever we do this, sometimes seizures may worsen, and that's something we have to discuss with the patient. Let's go a little bit in detail about these risks for the baby associated to the exposure in womb to antiepileptic drugs. The babies may have intrauterine growth retardation. The effect is not the same with all the antiepileptic drugs and is most pronounced with topiramate. And the functional consequences are still unclear, but there may be some, and we have to explain to the mother. Another major concern is the possibility that the baby is born with major congenital malformations. The risk is not the same for all the antiepileptic drugs and is not the same for all the doses. The highest risk is associated to valproate. Phenobarbital and topiramate are associated with an intermediate risk. And so far, the safest seem to be lamotrigine and levetiracetam. Both for valproate and for other drugs, for example, carbamazepine, phenobarbital, and lamotrigine, the risk is dose-dependent. So whenever possible, we have to lower the dose, making sure, of course, that the dose we choose is effective to have the patient without seizures. What happens with polytherapy is polytherapy more dangerous than monotherapy? In general, it is. But we have to take into account that the type of antiepileptic drugs included in the polytherapy is at least as important as the number of AEDs. So sometimes it may be preferable to use a low dose of 2 different antiepileptic drugs than a very high dose of one antiepileptic drug, depending on the antiepileptic drug we are speaking about. The positive and final message has to be that in spite of this increased risk respect to the women who do not have epilepsy, 96% of babies born from women with epilepsy will have no major malformations. Over the last years, we have discovered that sometimes the risk is not only of physical malformations, there may be a cognitive risk for the baby. Exposure intrautero to valproate is associated to a dose-dependent risk of lower IQ, and some neurodevelopmental disorders such as autistic spectrum disorder. This does not seem to be the case for carbamazepine or lamotrigine, for example. And there are still limited data regarding to levetiracetam, topiramate, and other AEDs in terms of later child cognition. We have spoken about the risks associated to the antiepileptic drugs, but what happens with risks associated to unexpected seizures during pregnancy? What's the information the women need to know? The woman needs to know that approximately 2/3 of women with epilepsy, when they become pregnant, they have exactly the same seizures that they were having before. But there is a percentage ranging between 15 and 30% who may experience an increase in seizure number. This may be due to lack of sleep during the pregnancy, labor, and after delivery, stress and anxiety produced by the pregnancy, to the hormonal changes, to the pharmacokinetics of several antiepileptic drugs whose blood levels decrease sometimes in a very drastic way during the pregnancy, and the most typical examples are lamotrigine, levetiracetam, and also carbamazepine, to the lack of compliance with medication of some women who are scared of the drugs having a negative impact on the baby. And of course, if we have changed the medication before the pregnancy, we may change to a not so effective drugs when we are looking for a better teratogenicity profile. So that may be another reason also. What are the risks of the seizures for the mother and the baby? For the fetus, it's clear. Generalized tonic-clonic convulsions can be associated in the baby to hypoxia, to acidosis, to fetal bradycardia. If the patient goes into a generalized tonic-clonic status epilepticus, there is a significant risk of fetal loss. And there has been at least one study that has associated an increased number of generalized tonic-clonic seizures, more than 5, with a lower IQ in the baby. Women with epilepsy during pregnancy have also more medical and psychological complications than women without epilepsy. They have an increased mortality rate during the hospital admission for delivery. And there are some studies that suggest that mortality is also increased in these women during the first year postpartum. So we need to keep an eye on the mothers also. How can we decrease all these risks associated to antiepileptic drugs and risks associated to seizures? When the woman is planning a pregnancy, we need to review the history carefully. We have to make sure our diagnosis is correct, the diagnosis of epilepsy, but also the diagnosis of the epileptic syndrome, and make sure the treatment she is on incorrect. Regarding drugs, we have always to balance the risk of seizures against the risk of malformations or cognitive problems induced by the AED. And we have also to consider the dose we are using of the drugs. Whenever possible, we have to avoid valproate. If the patient is on valproate, we need to go back in the chart and see if she has already tried other options that may be appropriate for her and have a lower risk for the baby. Whenever we have a patient on an antiepileptic drug, we need to consider if perhaps she could be on a lower dose, because we know all complications and risks are associated to the higher doses, but we need to take into account also the patient safety in terms of seizures. Let's imagine that the patient has been several years seizure-free, and the clinical criteria suggest that she has a high likelihood of being seizure-free after drug withdrawal. Perhaps we should try to stop the medications. And of course, we should encourage our patients to get pregnant when seizure control is adequate, because most women who are seizure-free before pregnancy remain the same during pregnancy, and this is going to be much safer for them and for the babies. If we decide that the combination the patient is having is too risky for the fetus and we change the medication or decrease the dose, we have to counsel the women about the possibility of seizure worsening. For this reason, we need to do these changes well in advance of the pregnancy, especially if we have to change completely the drugs the patient is on. Probably we should start to do this at least 1 year in advance of the expected pregnancy date to provide us with enough time to make the changes, make sure the patient is stable with the new antiepileptic drug, and find the minimum efficacious dose. If the patient worsens when we change medication, we need to consider further changes or return to the previous AED regimen, and we need to counsel and explain the risks again. In those drugs that we know that are going to be experiencing important fluctuations of blood level during pregnancy, such as lamotrigine, levetiracetam, oxcarbazepine, we need to obtain a basal blood level of the AED, so we have a target level that we can try to accomplish during pregnancy. What about supplementation with folic acid? Folic acid is recommended for women with epilepsy in fertile age who are taking AEDs. Why? Because it helps to reduce the risk of neural tube defects, and it should be taken at least 3 months before conception and at least during the first trimester. There have been some studies also that suggest that women who have been taking folic acid, the babies have a better IQ at 6 years of age. Because this should be started before pregnancy and there is a high number of unexpected pregnancies in women with epilepsy, probably what we should do is to give folic acid to all the women with epilepsy who are in fertile age. The recommendations about dose differ. At least the patient should be having 0.4 milligrams a day, but higher doses may be required if the patient has a personal history, a family history of malformations. What happens if the patient suddenly becomes pregnant and this is an unexpected pregnancy? We have to tell her to keep having her medication and contact us as soon as possible. We know that stopping abruptly the medication does not lower the risks for the baby and could provoke life-threatening seizures for the mother and a lot of complications for the baby. So this is something that cannot be done. I've had in my clinic patients who have gone into generalized tonic-clonic status after stopping medications because they found out that they were pregnant. We need to tell them that it is important to keep taking the medication they were taking initially. We have to be careful and preferably not to do any changes once the pregnancy has started, and tell them that being non-compliant can be very risky for them and for their children. Are the epileptologists alone with this counseling? We shouldn't be. This education and this counseling should be a multidisciplinary work involving different professionals working together for the health of the woman and the baby. So it's us, of course, the neurologists, but also the primary care physician, the gynecologist, the obstetrician, the epilepsy nurse, and the clinical pharmacist. All of them have a very important role in the education and providing the information needed so the patient can make adequate decisions. Once we've had these honest and thorough discussions with the patient and the family, our goal is that the patient and the family express their preferences for one or other option, and ideally we should have a joint decision regarding the pregnancy. And these discussions and the final decision that the family has agreed on should be recorded in the medical history of the patient. And to finish, just some takeaway messages. We have here a woman in different moments of her life since she is a little girl to the pregnancy. The first part of the slide wants to remind that education probably should begin with the pediatric neurologist if the patient has epilepsy since childhood. Once the patient is in fertile age, she should already be counseled about the convenience of not getting pregnancy and of course of the different and effective contraceptive methods. When the patient is grown up, she needs to keep talking about pregnancy, perhaps a preconception visit where information is shared across all specialties managing the pregnancy would be ideal. I don't know if it's feasible in all the countries and all the circumstances, but it should be ideal. We should provide, again, clear information, this time adapted to the age of the patient, and we should start the patient on folic acid independently on the fact that she wants to become pregnant immediately or not. When she is ready to become pregnant, we need to get together again. The neurologist needs to make a careful reassessment of the antiepileptic treatment. We need to inform the patient about risks for the baby and for her with the particular antiepileptic drugs she is on. And we have to tell her that we may need to modify the antiepileptic drug regimen to adjust the dose and to monitor closely the blood levels, the seizure frequency, and in general, her general well-being during the whole duration of the pregnancy. Thank you.